Hello everyone and welcome. My name is Matt Russell and I'm the Sales Director at Lorraine Medical. And we're the proud sponsors of this afternoon's symposium on lessons learned on introducing a statewide digital platform in Western Australia. This project is aimed at supporting the reduction of diabetes-related foot complications across the entire Strait of WA. It's my pleasure to introduce our two presenters. First up will be Dr. Olufemi Oshin. Dr. Oshin is the Medical Co-Director and Consultant Vascular Surgeon at Royal Perth Hospital. As you can see from his bio, Dr. Oshin brings considerable passion and expertise to this project. As one of the two originating clinical sponsors, he has been heavily involved in the leadership role right from the start. Next, we will hear from Dr. Lorraine Anderson. Dr. Anderson is the Medical Director of the Kimberley Aboriginal Medical Services, or CAMS as they are known, and is based in Broome in the north of Western Australia. As you will see from her bio, Dr. Anderson also has considerable expertise and passion in improving outcomes for patients living in remote communities. The team at CAMS are the ones working directly at these at-risk patients in the Kimberley. You will have the opportunity to ask any questions, so please enter these in the chat box as you think of them as the session progresses. We will answer them once both speakers have finished. So please join me in welcoming our first presenter. Over to you, Dr. Oshin.
Thanks, Matt, for the introduction, and thank you to Which Australia for having me present at the conference, and thank you all for listening to this presentation. So I'm going to cover diabetic foot disease and going digital. And in my slides, I'll cover the problem that we face, the challenges that we are dealing with in trying to find a solution, the vision that we developed through this process, and the journey that we undertook to realize that vision. And finally, I'll finish with the lessons that we have learnt on the journey that we have gone on. So diabetic foot disease is a problem. That's why we're all here. And as you may well be aware, it is the top 10 cause of disability globally and is responsible for around 4,500 amputations every year in Australia. And that's approximately 12 per day. There is a human cost to this, which is the loss of workforce and potential income, and also the loss of quality of life, not just for the individual affected, but also for the people around them. On top of that, there is a financial and economic cost to this. And in Australia, that price tag is almost $1 billion per year. So to manage this problem, we need high-quality diabetic foot care. And that's particularly important because we know that 85% of diabetes-related amputations are preventable. But that is only if the wounds are detected early and managed appropriately. Underpinning all of this is the concept of equity of access to high-quality diabetic foot care, and also excellence when you do make contact with the healthcare professionals. And we're not just talking about one or two individuals here, we're talking about quite a large team that are involved in the process of limb salvage and trying to reduce avoidable amputations in the diabetic foot setting. And with this team, we can achieve quite amazing results. In this particular series of images, we have somebody who's had quite significant and traumatic limb salvage procedures being done in order to control diabetic foot disease. But through the work of a specialist multidisciplinary team, we've been able to salvage the limb and ensure that the patient is able to ambulate going forward into the future. We also live in a really wonderful place in WA with some beautiful natural scenery, but in these rural and remote areas, they are also hotspots for an explosion of diabetic foot disease. looking forward into 3 or 4 years down the line. And we've done some modelling which shows that it is also going to be an issue in places that are in and around the metropolitan areas as well. So this is not just an issue for remote and rural communities, but also something for the whole of Western Australia. And in these rural and remote settings, there are particular challenges. For the Aboriginal people who live there, they are 3 times more likely to have diabetes, 10 times more likely to have or be admitted with diabetic foot disease, and unfortunately are overrepresented in the population of people undergoing major amputations. In fact, they are 30 times more likely to have a lower limb amputation. Added to that are different perceptions about health, which may impact on their prioritization of healthcare, poor transport between communities and also to regional centres, and a reluctance to travel to metropolitan Perth to receive treatment because it really removes them from familiar settings of their home and family. For the healthcare workers that work in these areas, there is the risk of professional isolation and potential barriers to professional development due to the geographical location. There is also limited access to drugs, imaging, technology, and specialist expertise, and all this can result in a transient workforce which is not conducive to providing consistent, high-quality diabetic foot care. The end result really is that we have a lot of people who present very late with advanced diabetic foot disease, which severely limits our options in metropolitan Perth when it comes to limb salvage. And sadly, a lot of people present with a situation where we don't have much option but to perform an amputation. So action is required, and that can take many forms. That's workforce development, both for podiatry and Aboriginal healthcare workers, who are critical in this area, integrated referral and escalation pathways, interprofessional learning and three-way learning. And on that specific point, we really need to remember that we need to involve the consumer in this as well and make sure that we're designing pathways that are going to be sustainable going forward. With specific reference to the Aboriginal population, we need to think about cultural security and their involvement in the pathways that we're trying to put together to improve the quality of care that is being delivered. All of this, I think, can be advanced by using technology to overcome the geographical barriers and essentially shrink what is one of the largest inland states in the world, in WA, to a really small area that can enable communication between various healthcare professionals. The other thing that we've learned of late is that COVID is not just a rural issue, and certainly with the mandates to socially distance, we've had to really embrace the use of technology and digital technology in the COVID era. The final thing that I think is important is really this concept of closing the gap. We've known for a long time, as I've alluded to before, about the disparities between our Aboriginal population and the non-Aboriginal population. And there have been several initiatives to aim to try and close the gap, but I think we have a real opportunity here with what we're doing here to really try and make some inroads into that. When we think about the usage of health services, and if we take the example of a diabetic foot disease, most people with a diabetic foot problem will have some contact with the health service. And at point A, something will happen, which requires either admission or an interaction with the health service. That will take them up to point B, and then afterwards, they will require a greater degree of contact with the health service. And this is where the financial burden comes in. Now, if we're going to improve outcomes, we can either delay the point at which they have some sort of critical event that brings them into contact with the health service, or we can reduce the amount of times they make contact with the health service, which will also reduce the expenditure, or we can try and avoid them ever having an intervention in the first place. And with all of those strategies that I've outlined, using technology is something that I think can play a significant and integral part in making that a reality. So our vision was really trying to break down what medicine is all about, and that's data gathering, interpretation, and developing a solution to the problem, which is, in medical terminology, a diagnosis and an action plan. However, the solution is only as good as the initial data that is presented. And this is where we started thinking about the concept of a statewide solution for diabetic foot care, and specifically tracking foot wounds. And with what we're proposing, we're talking about a standardized, high-quality data set which provides better solutions. It potentially obviates the need for face-to-face consultations and facilitates flexible, convenient, and remote working, which is beneficial to patients and clinicians alike. But I think importantly for us in Western Australia, this aligns with our digital health strategy, which is really a body of work that we've been engaged in for a number of years now to try and engage with and support and promote digital health strategies. So a little bit about the technology that we're discussing today. The heart of all of this is really the Silhouette Central server and data storage capacity. And that allows us to send data in through handheld devices or a wired Silhouette Star camera, which is located in the clinics. And through that, we can record data about the wounds and also about the interactions. And that also enables us to put out information for the purposes of reporting and communicating with other clinicians and primary care. It also has the potential to operate with third-party electronic medical record systems. So for our inpatient management systems within the hospital, there is a possibility to pull information directly from that, such as demographic data, which helps with our clinical workflows. So part of the components I mentioned, the Silhouette Star, which is the handheld camera. This can be operated with one hand, and in this area where we are particularly mindful of infection prevention, it is important to note that it can be cleaned with surgical wipes. This camera captures 3D images using lasers and is able to give us information about the surface area, depth, and volume of the wound. And by taking serial images, we are able to track the wound's progress and really only intervene when it is necessary. A similar technology exists that is mobile, which can be attached either to the iPhone or an iPad, and which is particularly useful for use in wards or the community setting, and can provide similar information. But rather than being able to provide 3D measurements, it provides two-dimensional measurements, which, while not as good as the Silhouette Star camera, still provides useful data that can be used to track wound healing trajectory. So our journey to get to this point really began for me in 2017 when I met Professor Janssen at the Diabetic Foot Australia conference, where we discussed and I was introduced to the concept of the Silhouette camera. And we talked about this concept of regional networks to share data and facilitate clinical care. This led to the submission for a research proposal to try and fund this, but unfortunately that was unsuccessful. But I did have the opportunity to meet my co-presenter, Lorraine Anderson, during the process, and we really thought about alternative methods of funding this important initiative. By March of 2019, I then met Sophie McGough from Diabetes WA, and we decided to expand this idea from just simply a regional-based referral pathway to one that was a statewide proposal. And we began discussions about the IT infrastructure, and we then managed at Royal Perth to get a loan camera from Aranz to support our clinical workflows and start thinking about how we can embed it into daily practice. By the time we got to August of 2019, Diabetes WA had fully committed and taken a plunge and procured 7 Silhouette Star cameras, which was essentially the beginning of the network. We established a training program that I was proud to be part of in Broome to train our Aboriginal healthcare workers. And at Royal Perth, the procurement process began to complement the existing 7 Silhouette Star cameras. By January of 2020, the Silhouette camera devices arrived at Royal Perth, and we were able to incorporate that into our workflow. Then in March of last year, COVID hit, and that really sort of put a spanner in the works for a lot of innovation and development. And for a long time, we were consumed with COVID. But in the last 6 months, things have picked up again, and we've been able to continue the development of this process. And a couple of things have happened. We've migrated our Silhouette software from a standalone physical server, which is located at one of the hospitals, to the cloud, which meant that it was accessible to all the health service providers in WA by virtue of being on the cloud. This migration process did unfortunately stall the clinical workflows at Royal Perth, and in particular, we were unable to use the Silhouette lights because of firewall issues that is currently being worked on at present. We did, however, manage to re-engage and retrain our Aboriginal health workers, and we've been able to establish access to the Silhouette Central for some of our rural and remote sites, which meant that we've been able to share clinical data between those sites and Royal Perth. And that has meant that we've been successful in instituting management plans for some of our patients. We have successfully shared, as I said, clinical data for some of our rural patients, and that has meant that for some patients, we've been able to institute management for them in country without requiring them to come to metropolitan Perth. I've outlined a rather linear progression of events, but in reality, our journey has been more like a spaghetti hoop, really, with lots of backwards and forwards and lots of challenges and ups and downs, as well as some wins. We haven't quite reached the end, and I'm sure there'll be further challenges, but that is the reality of our journey so far. So what have we learned throughout this process? I think the first thing is that there needs to be a broad coalition of people involved in this for success. That means end users, which are both clinicians and patients. The Aboriginal community-controlled health services are an integral part of this. Non-governmental organisations such as Diabetes WA have been pivotal in really being the early adopters and helping to drive this initiative forward. And of course, within the central tertiary centres, we've needed support from the hospital executive. I'd also like to pay tribute to the Around's team who've been extremely patient and stuck with us throughout this really rather convoluted process, and have been a big help in terms of trying to get us to where we are today. The second point I'd make is that if clinicians want it, it will happen eventually. Once you make a clinical case for a lot of things in health, usually things happen, even though it will be slow. But you do need to be prepared for skeptics. Not everybody is an early adopter, and not everybody will sign up to this from the get-go. So you need to have a process in place to manage that. Project support is critical for this, and that's primarily really with regards to change management. As clinicians, we can inform that and help to support that, but you do need somebody that's dedicated and dedicated resources to actually engage with people and do a lot of the legwork that is required to make this work. And part of that is really knowing how to manage expectations. There's a lot of promise with this vision in terms of how it will revolutionize and make life easy, but integrating it into the clinical workflow can be challenging. It's a new device, and using it in day-to-day clinical practice may be something that takes some time for people to get to grips with. So managing those expectations and managing the milestones by which you expect to see improvement is something that one needs to be conscious of. Time is an important thing. From a clinician perspective, I think it is important not to have just one clinician engaged in this, but several. We end up with multiple commitments, and sometimes what you don't want to do is end up with a situation where you're waiting for an answer from a single clinician, which may not come for several weeks, because that will simply just delay the implementation process. From an IT perspective, they're critical, but you need one individual who knows this backwards to help maintain the progress. Finding an IT person that you, or speaking to somebody at the help desk that you need to constantly sort of mention and explain from scratch what the concept is has proven to be very difficult. And I guess the last thing is, what have we learned? Just do it and ask for forgiveness later. I think if we hadn't have gone off and bought through the help with Diabetes WA a critical mass of cameras, a lot of this wouldn't have happened. What we've been discovering as we've gone along with regards to developing the IT architecture and things like that, having those cameras as a big white elephant in the room has been a significant and important lever to get things going. And I think the most important thing really is don't give up. This is and can be quite a hard road to travel, but it is ultimately rewarding as we now are on the cusp of developing significant infrastructure which will really augment the care that we are delivering. And I think the final thing is really, why are we doing this? And this is really about the people with diabetic foot disease. And there is a saying that in the Kimberley, if you save a foot, you save a community. And I think that's very poignant because if we can get early engagement, get people to participate in this, support and promote local services, then we will always get better outcomes. Because really, we really only should be seeing the people who can't have intervention locally because of specialized equipment, rather than lack of availability or lack of intellectual or knowledge or ideas or specialist input in a multidisciplinary setting. So thank you for having me, and happy to take any questions.
Hi everyone, and thanks Femi. I'd like to begin by acknowledging the Yawuru people as the traditional custodians of the lands on which I live and work, and pay my respect to ancestors and elders past, present and emerging. My Aboriginal ancestors lie in Tasmania, which is a long way from here, and a connection I have through my father. It's important we all recognise our continuing connection to lands, waters and community, and respect the differences we all bring to the table. I'm also a rural GP working in the Aboriginal community-controlled health sector in Western Australia, and the medical director at the Kimberley Aboriginal Medical Services, also known as CAMS. I was born in New Zealand in a small town called Whakatane and trained at Auckland Medical School, so you will detect a slight Kiwi accent still. I met Femi 2 years ago when he gave a talk at the Aboriginal Health Council of WA conference in Perth. We connected through our mutual desire to improve foot health in remote Australia. Over the last 2 years, we've worked on a research proposal, the introduction of the silhouette cameras to the Kimberley region, and the implementation of the Kimberley Foot Initiative. We've needed to be very patient because, as Femi says, the wheels of health roll very slowly. But looking back over the last 2 years, we've made some good inroads into our sustainable model of foot care for our remote living people with diabetes and diabetic foot problems. And we're looking forward to seeing some measurable changes in the years to come. So to set the scene, I'm just going to introduce the Aboriginal community-controlled health sector, which we also call the Arches, and just show you how CAMS fits into that. So CAMS is a peak organisation in the Kimberley region of the far north of Western Australia. We provide governance and support services, both corporate and clinical, to the Arches member services in Broome, Derby, Halls Creek and Kununurra. We also directly provide clinical services to the remote communities of Bidjadanga and Beagle Bay, which are approximately 200 kilometres north and south of Broome, and also out to Balgo, Billaloona and Mullen, which are communities over 1,000 kilometres east of Broome in the desert. In addition, CAMS manages the Broome Headspace and the Kimberley Renal Services. The renal services provide dialysis in Broome, Derby, Fitzroy Crossing and Kununurra, and will soon be opening a dialysis unit in Halls Creek. So in addition to dialysis, we also provide pre-dialysis and early renal disease management of patients in the Kimberley. So CAMS is part of a large network of ARCHES providers in the state. And for those that are not familiar with ARCHES, these are Aboriginal community-controlled health services. So they're owned and governed by the communities they serve. Amputation is a big problem for us in the Kimberley. Aboriginal people are 38 times more likely to undergo a major lower limb amputation compared to non-Aboriginal people, and 27 times more likely to undergo a minor lower limb amputation. And diabetes is associated with 98% of these amputations. There's a 3 to 6-fold increase in the risk of likelihood of Aboriginal and Torres Strait Islander people developing diabetes foot-related complications. And the onset of these complications on average is 14 years younger than in non-Aboriginal people. So there's a concern that a lack of foot care is leading to serious consequences for people living with diabetes in remote Kimberley communities. And this has prompted CAMS to harness new technology to reach those in need. Diabetes WA furnished CAMS with Iran's medical Silhouette Star point-of-care devices that enable Aboriginal health workers in remote communities to accurately image, measure and record data on wounds, ulcers and other foot problems. The Silhouette camera, which is pictured here, is easy to use and it provides a 3D measurement, consistently lit images at the click of a button. The data captured is managed through software on laptops, showing the size and depth of a wound, ongoing comparisons, consistent information. This is very important for us because our staff work on a roster and it's not always the same clinician who sees the wound and images it. So the Silhouette Star provides consistency in wound management. There's also the Silhouette Lite Plus, which is an app that works on mobile devices. This technology is exciting and an advancement that will give us better reach into the community with mobile devices. Both of these devices are non-contact, which is good for the patients and provides infection control. So once a photo is taken, the image is uploaded to Silhouette Central, which is a cloud-hosted secure site. From here, other health professionals can access the image and then give advice. Health professionals accessing the images are GPs, podiatrists, wound specialists and vascular surgeons. Without Silhouette, the patient would have to make a very long trip out of their community to access this level of assessment. Kimberley people travel across the region a lot, but not so much out of the region. So a trip to Perth to a tertiary hospital is quite a daunting prospect, and a number of our people don't attend their appointments. Having the ability to use this form of telehealth to connect with our surgical colleagues in Perth is a win for the patients, and we believe will lead to increased attendance for wound care. So this comprehensive reporting, from the Silhouette Central database, we can get some comprehensive reporting and the ability to compare images as the wounds change with time, and this is very valuable. So just to give you an idea of some of the distances, New Zealand is approximately 600 kilometres in length from the top of the North Island to the bottom of the South Island. And to give you some perspective, the drive from Broome to Perth is 2,223 kilometres. So Western Australia is an enormous state. Even across our region, the distance between Broome in the west and Kununurra in the east is 1,044 kilometres. So the management of patients across large distances is now possible and acceptable to both the clinician and the patients using technology like the silhouette camera. You might be interested to know that the World Health Organization used the silhouette for research to simplify and reduce the cost of treatment for the Burley ulcer at 4 trial sites in Ghana and Benin. World Health Organization used silhouette for a study on these ulcers, and the data was remotely accessed by key researchers in France, the Netherlands, Switzerland, the USA, and using the cameras, the Silhouette Central via the internet. So Kimberley countrymen like to travel through the various communities and therefore tend to see multiple clinics for their care. In the Kimberley, we have a shareable electronic record system, and now with access to the Silhouette Star, we're able to care for the same wound objectively, even if the patient sees multiple providers in multiple locations. Aboriginal health workers are able to connect with patients with foot problems, monitor their care, and help prevent that patient from having to go down to Perth and potentially undergo an amputation. This is a photo of our Aboriginal health workers working in our Beagle Bay clinic with the Silhouette camera. So the Kimberley Foot Initiative, last year, CAMS received funding from the South Australia Health and Medical Research Institute, or SAMRI. And this was to look at a plan to reduce the amputation rate in the Kimberley. SAMRI are assisting a number of regions, including the Kimberley, to design and implement a foot program that works in the area. So basically, we got a mandate to come up with an initiative that was going to work specifically for our region. The funding was aimed at the implementation of this regional evidence-based initiative. And the initiative is designed to increase access to multidisciplinary care for Aboriginal and Torres Strait Islander people who are at risk of diabetic foot disease or who already have diabetic foot disease. It also supports the Aboriginal and non-Aboriginal health workforce to better respond to the needs of Indigenous patients with foot complications and associated disorders. And it utilises best practice models of care and explores novel approaches for treating Indigenous people with or at risk of diabetic foot complications. And that's in the primary, secondary and tertiary services. The initiative is also looking at best practice community-based workforce modelling for multidisciplinary allied health approaches to prevent and treat diabetic foot complications. And it involves education and upskilling for the workforce in our remote clinics. So CAMS manages the delivery of this project in the Kimberley and with the aim of reducing the diabetic foot-related complications and amputations for Aboriginal people. So the location of the Silhouette Star scanners in the Kimberley at the CAMS sites are Derby Aboriginal Medical Service, Broome Regional Aboriginal Medical Service, Bijadanga Health, the Ord Valley Aboriginal Health Service in Kununurra, Urayungi Medical Service in Halls Creek, and the Kajunka Health Clinic in Balgo. And also Beagle Bay. So cultural security is central to the development and success of this regional initiative. Consultation with the archers, who are governed and staffed by their Aboriginal community members, has been instrumental in ensuring the approach and priorities of the plan is aligned with the needs and aspirations of the Kimberley Aboriginal people. So in light of COVID and travel restrictions to Aboriginal communities, archers have directed a phased approach to implementing the action plan. So I'm just going to explain to those of you who are not in Australia that throughout the COVID pandemic, the remote Aboriginal communities have actually been closed. And that means closed to visitors coming in. The people in the community can come and go as they please, but there's been no tourists through our remote Aboriginal communities for over 12 months now. So phase one of our project, the Kimberley Foot Initiative, is focusing on actioning the gaps identified in the secondary care space and implementing the Silhouette platform for imaging foot wounds. So there are many positives in the work that we're able to do under this initiative. Perhaps the most obvious is that Silhouette has improved service integration and shared care between primary, secondary and tertiary services for those with active acute foot problems. What's been good? We're confident we'll see an increase in the treatment of chronic foot problems and limb salvage surgery occurring in the Kimberley. We'll also see an increase in Aboriginal health workforce capacity and confidence in their ability to assist in foot screening and assessment. And we'll also see an increase in Aboriginal health workforce capacity and confidence in providing culturally and regionally adapted foot care education. And what hasn't worked so well, and what we would recommend to others, is that we did have problems with the state health firewalls, which initially didn't allow us access to store the images in a shared cloud space. And this has been tricky to negotiate, but not insurmountable. The other thing that I would suggest watching out for with an initiative like this, and also with the Silhouette cameras, is making sure that the staff remain confident with using the technology. And this confidence using technology falls off quickly, so the staff are encouraged to continue to use the scanners frequently and remain confident and competent. We're also doing a lot of upskilling and supporting our remote staff. That support's coming from the visiting podiatrists and also through telehealth and ongoing education. And we believe these are important aspects to making this whole project successful and sustainable. So if you're interested in our work, I would encourage you to keep an eye on our website, cams.org.au, and you might also be interested in the various protocols we have available on the Kimberley Aboriginal Health Planning Forum, the CARF website there. I'm also happy to receive any emails if you're interested in any more detail. And of course, Arans are available to talk to you about the Silhouette Star camera at any stage. Thanks very much for listening.
Thank you very much, Femi and Lorraine. Very enlightening and illuminating, and wonderful to have two people speak with such honesty about both the pros and the cons of what you've done. Certainly from our side of things, it's been a great honour really to be able to have our technology supporting what is really a both state and national initiative to improve the quality of life for those people unfortunate enough to have diabetes-related foot ulcer problems. So I'm going to kick off with a couple of questions. First of all, Lorraine, for you, you are, of course, a long way away from anywhere, as you've so accurately described. How has it been for the Aboriginal health workers to adopt the technology in this new project?
Yeah, thanks. Look, the Aboriginal health workers have actually taken this on board really well. They really enjoyed the training that was provided, and in particular, having Femi around to help them with that training was really good. The we don't have a problem with people adopting technology out in our remote clinics. I think prior to COVID, there was an acceptance that this was the way forward, and COVID just springboarded us into that, basically. What we were thinking was going to take a few years to really get up and running in terms of getting some technology going in the communities actually happened pretty much overnight when we closed our communities down and stopped lots of people travelling in and out. So the Aboriginal health workers have taken this on board. The majority of our health workers have been trained in the use of the camera, and they've gone back to their clinics and continue to use them. I guess hoping that that they will pass that knowledge on as well through the other clinicians in the clinic.
Great. For those of you who have been listening to the session, I'd encourage you to use the chat for posting any questions that you would like to pose for Lorraine or Femi. Femi, the next question I have is for you. It's pretty unusual, really, for projects to involve major metropolitan hospital clinicians and people so widely dispersed into the remote regions. How has this project aligned to the Western Australian IT strategy for putting in diverse systems to be used by multiple groups of people?
Thanks for the question, Matt. I think it's not so much a strategy per se for IT, but it's more much broader than that, and really talking about sustainable health and our digital strategy for delivering that in the long term going forward. And I think, as I discussed in my talk, the key part of that is really sort of capturing the digital space. So we have, set targets for the amount of telehealth which we want to deliver to patients in the country regions and also those in the metropolitan regions. COVID has helped us sort of achieve that, but we've seen a dip in that and a fall off as some of these restrictions have started to be eased. And that's a bit unfortunate, really, because I think there is really an opportunity here to start doing things in a different way, really capitalize on some of the exciting new technology that's available here, and also do things for the convenience of the patients, really. With regards to how this project aligns with that, it ticks a lot of the boxes, really. It spans multiple specialties, not just the diabetic foot area, but also plastic surgery, something that can benefit from this sort of technology, dermatology, anyone that has a wound essentially can benefit from this technology. And the great thing about it is, being able to have this central repository where you can have multiple conversations across multiple specialties to really deliver the best outcome for the patients.
Thanks, Femi. We have our first question from Sareed Martin. This is a question, I think, directed to you, Lorraine. So the question is, has the training of the Silhouette camera also included upskilling of the Aboriginal health workers' foot screening and DFD identification skills?
Yes, it has actually, and that's been a very important part of the diabetic foot initiative that we're running in the Kimberley. So one of the really important aspects and phases of this initiative is actually the upskilling of the Aboriginal health workers staff in foot care. So we've got quite a bit of training going on. Some of that's online, some of that's in person. And we're also developing one of our Kimberley protocols into something that's actually usable for the health workers in terms of diabetic foot assessment. We also have, through our software, so medical notes software, we actually have the ability to set up a template so that people can walk their way through the template, making sure that they're covering off on all aspects of the foot care and foot assessments that they need to. So that's actually been a very important part of the foot initiative, and it's ongoing. So we're developing that every day. We're training every day, and upskilling is happening every week.
Great. I have a question which is often, I think, overlooked, which is money. Where does the money come from? This is a big project in terms of all the people who are involved. It's a big project in numbers of groups. Perhaps maybe even start with you, Lorraine. Where were you able to source money from, and do you have any ideas for the future where you might look for funding?
Yeah, funding is always an issue. It doesn't matter whether you're in Aboriginal health or mainstream health, whether you're in non-government or in government health. So look, we were lucky enough, in particular for sourcing the Silhouette Star cameras, that Diabetes WA, through a very generous donor, actually provided us with the cameras. So that was a real bonus for us. There is a small cost ongoing with the use of the cameras and the use of the software, which is pretty easy to absorb. As far as staff are concerned, and the cost of staff, our idea is to actually integrate this into our core service. So when you come in for a diabetes check and we check your feet, if there's anything going on, we'll use the Silhouette Star camera, and we'll follow the diabetes foot protocol. So in terms of capacity within the staff, it's actually something that's going to be integrated into what we do every day, and so our core business. I think going forward and developing this further, and in particular doing some research, which I'm sure Femi will comment about in a minute, we are really keen to research good outcomes from, or at least evaluate good outcomes from what we're doing, and certainly through the Kimberley Foot Initiative that we're running, we have got some funds which has come through a research partner and through the Commonwealth of Australia. There is some money there to do an evaluation, and we've also got another research project that Femi is involved in as well, looking for funding to move that forward.
Femi?
Yeah, I mean, funding is always something that is a big thing to think about with all of these projects, as you've quite rightly said, Matt. And just talking with my other hat on as a hospital administrator, one of the things that you learn is that a lot of this is actually about shifting costs. And, it's very rare that you get new money that sort of comes in to help sort of support or drive these new initiatives. And I think one of the things that's very clear to me is that we quite often get patients that are transported from the Kimberley to Metropolitan Perth for consultations, and that costs a lot of money, not just in the air travel, but also in accommodation for the patients when they arrive in Perth. Often it is not unusual to require a companion with the patients as well, because they are coming to unfamiliar territory. So I think by shifting into that sort of digital space, you shift the costs, and whilst you can sort of do some upskilling and some of the outlay to sort of get the infrastructure up and running, what you're actually doing is just diversifying your focus of where the funds are going. So I think overall, I'd like to say that it comes out as cost neutral, but it's probably not true. There's a requirement for a bit of investment, which will sort of come down as take-up increases going forward and people get used to the technology. And just to come back to the earlier points with regards to upskilling and things like that, that is absolutely crucial with regards to providing the range of information that you need to make your assessment. As I mentioned in my slides, it's really about getting good quality information to actually make that decision, and then having somebody at the other end that can actually go forward and perform the action that's required.
Thanks, Femi. Look, my last question to you, Femi, is we've spent a lot of time talking about the issues in the Kimberley, which are significant. In your presentation, though, you also identified a couple of hotspots that are really in the metropolitan areas around Perth. What is the plan for addressing those as part of this project?
Thanks for that, Matt. I think, it's pretty aspirational, really, because I think what we need to do is really get the ball rolling and get more and more people involved and comfortable with using the technology. And I guess my vision of this going forward would be that even in the metropolitan areas, in podiatry clinics within the metropolitan areas, what we're trying to do is promote ease of access and that sharing of information so that we've got rapid escalation and an easy way for people to ask for help if they need it. If we can get access to people, even in the metropolitan areas, in those hotspots that I described, then we'll get better outcomes because people will be able to present earlier and they'll be able to get the care that they need when they need it.
Brilliant. Well, I think we're drawing to a close. Thank you very much, Femi and Lorraine. I've very much enjoyed your presentations. I am also in New Zealand, so it's late here, and I'm going to close off and go and have some fish and chips for dinner.
Good on you.
Bye-bye, everyone.
For having us.
Thanks. See you.